Imagine battling a routine, incredibly common infection. You feel the symptoms, you take the standard medication, the culture eventually comes back clean, and your doctor confidently gives you a clean bill of health.
Right, which should be the end of it.
Exactly, but it's not. You are left behind with this devastating, chronic, burning nerve pain that just, makes daily life completely agonizing.
Yeah, and because the original infection is, demonstrably gone, patients are so often told the pain must simply be in their head.
Which is just awful. So today, we are looking at how a common yeast infection physically, like structurally, rewires your nervous system.
It really is a fascinating, albeit deeply painful biological paradox. We're looking at a clinical landscape where patients present with this excruciating localized pain, but the original fungal culprit has entirely vanished from the tissue.
Yeah.
So the standard diagnostic toolkit just suddenly feels utterly inadequate.
Okay, let's unpack this. We're pulling from a rigorous stack of clinical literature today for this deep dive, specifically the BAHH National Guidelines, the NHS Lothian Clinical Pathways, and these comprehensive medical reviews by researchers like Lusink and colleagues.
Right, some really dense material.
So very dense. But our mission is to cut through that jargon. We're focusing squarely on the exact diagnostic criteria for treating cyclical recurrent vulvovaginal candidiasis, specifically when it triggers temporary vestibular hyperalgesia.
That's a mouthful, but yeah, it's crucial.
It is. We want to understand exactly how doctors disentangle an active infection from the lingering nerve damage it leaves behind.
And to start that disentanglement, we have to be extremely precise about the conditions we're dealing with because well, the clinical terminology actually dictates the entire treatment pathway.
Right.
We aren't talking about a standard acute yeast infection that clears up and just never returns.
Yeah.
The BHHH guidelines define recurrent vulvovaginal candidiasis, RVVC, as a highly specific cyclical pattern of disease.
Right. In reading through the pathways, I noticed the threshold isn't just getting an infection like a couple times a year. The strict clinical definition requires you to experience at least 4 symptomatic episodes within a 12-month period.
Exactly. 4.
And furthermore, at least 2 of those have to be lab confirmed. And crucially, one must be confirmed by an actual culture, not just a quick swab. So this isn't just an annoyance. This is a sustained, repetitive, inflammatory assault on the vulvar tissue.
It is. 4 distinct inflammatory cascades a year is just a massive burden on the local immune system. And that brings us to the resulting pain condition, which is provoked vestibulodynia.
Okay, so how does it differ from normal pain?
Well, in pain theory, this shifts the patient completely out of the realm of nociceptive pain, which is, that helpful protective pain you feel when touching a hot stove.
Right, the move your hand pain.
Exactly. It plunges them instead into pathological neuropathic pain.
And the guidelines describe this neuropathic pain as a severe burning, stabbing, or like a shooting sensation localized right at the vulvar vestibule, which is the tissue directly surrounding the vaginal opening.
Yeah, and the medical literature draws a direct, unmistakable line between these 2 distinct diagnoses.
I saw that. The Lusink review actually points out that a history of RVVC is the absolute most commonly reported feature in patients who go on to develop this localized vulval pain.
It is incredibly consistent across the epidemiological data, and we don't just rely on retrospective patient reporting to establish this link either.
Oh, really?
Yeah. Experimental animal studies specifically involving mouse models that are subjected to repeated induced fungal infections, they've definitively proven this association. The repeated pathogenic exposure directly and mechanically causes the persistent pain state.
Wow. So it's kind of like having a smoke detector in your house. The cyclical yeast infection is the smoke, and it triggers the alarm.
That's a great way to look at it.
But what's happening here is that even after you put the fire out, clear the smoke entirely, and sanitize the room, the alarm's internal wiring gets physically fused. It just keeps shrieking.
Yes, exactly.
The body is sounding a massive, blinding pain alarm for an infection that has already been entirely eradicated.
And that altered wiring is the crux of the pathology. If we look closely at the peripheral tissue level, the local immune system's response to these recurrent fungal invasions becomes profoundly maladaptive.
How so?
Well, specifically, local mast cells in the vestibular tissue become highly upregulated and densely populated.
Now, we usually associate mast cell activation with allergic responses, right, like histamine cascades and anaphylaxis.
Exactly.
But the literature shows they are doing something far more insidious in this specific mucosal environment. These upregulated mast cells begin overproducing a protein called nerve growth factor, or NGF.
Yes. What's fascinating here is that the nerve growth factor does exactly what its name implies, but in the absolute worst possible location.
So it's growing nerves where it shouldn't.
Precisely. The excess NGF in the tissue induces the local terminal pain nerve fibers to proliferate. They rapidly multiply and physically grow outward, migrating toward the most superficial layers of the introital mucosa at the vaginal opening.
Wow, so the tissue is literally growing a denser, shallower network of pain wires. You have significantly more sensors, and they are entirely exposed right at the surface.
Exactly. And that directly explains the two distinct clinical symptoms doctors are testing for and the diagnostic criteria.
Which are hyperalgesia and allodynia, right?
Yes. With hyperalgesia, those hyperresponsive, dense nerves amplify a mild pain stimulus into something completely agonizing. But allodynia is even stranger. It's a complete sensory misfiring.
Wait, what do you mean by sensory misfiring?
Well, allodynia represents a fundamental shift in how the central nervous system interprets sensation. A normal, non-painful tactile stimulus, say, the gentle pressure of a cotton swab, or even just the friction of clothing, is perceived by the brain as a severe burning pain.
So a soft touch literally feels like fire.
Yes, the neurological translation is entirely crossed. Furthermore, because of the complex neurogenic pathways at play, these hyperactive nerves release neuropeptides that trigger neurogenic vasodilation.
Okay, and vasodilation means blood vessels expanding.
Right, which causes visible, persistent erythema or redness in the tissue.
Here's where it gets really interesting. If the body's own immune defense, these hyperactive mast cells, is physically overwiring the pain sensors, that perfectly explains the diagnostic tragedy we see so often.
The psychosomatic misdiagnosis.
Exactly. A patient comes into a clinic screaming in pain from a simple touch. The doctor swabs the area, sends it for a culture, and the lab sees absolutely zero yeast.
Right.
So without an understanding of this cellular nerve proliferation, the doctor just assumes the pain is psychosomatic.
It is a systemic failure in clinical understanding that we are, thankfully, slowly correcting. Because the yeast is gone and the culture is negative, a clinician might logically conclude there's no physical pathology present.
But they'd be wrong.
Very wrong. The anatomical changes, the superficial nerve density, and the central sensitization are entirely physically real. The pain is not in the patient's head. It is deeply rooted in structural, microscopic changes to their peripheral nervous system.
The psychological toll of being told a devastating, life-altering pain is imagined. I mean, that cannot be overstated.
It's heartbreaking. Patients often bounce between specialists for years before finding a clinician who actually understands the mast cell mechanism and can map the nerve damage.
And that brings us to the core challenge, disentangling the active infection from the residual sensitization. Because if a patient's tissue is structurally overwired, the absolute worst thing a doctor can do is just reflexively prescribe another antifungal cream the moment the patient reports a burning sensation.
The reviews, especially Lusink et al., are emphatic on this warning. Throwing topical or systemic antifungals at residual nerve pain is a massive clinical misstep.
Because it doesn't do anything for the nerves.
Not only is it fundamentally useless against altered nerve wiring, but the vehicles and preservatives in these topical creams can be profoundly irritating to an already hypersensitized vestibular mucosa. You are essentially rubbing harsh chemicals directly into exposed hyperreactive nerve endings.
Ouch. So the diagnostic criteria have to be incredibly rigorous to prevent that from happening.
That's absolutely.
To prove the pain is being triggered by an active cyclical infection, the BIAS-HH guidelines insist on moving past simple microscopy. Like for a first-time acute infection, looking at a slide under a microscope in the clinic might suffice. But for RVVC, you absolutely need a lab culture.
A culture is non-negotiable for two distinct reasons. First, it identifies the exact species of the yeast, which we'll see in a moment is critical for determining the treatment protocol.
Right.
Second, it dictates the specific sensitivity of that yeast to different antifungal medications. We cannot guess what we are fighting or what drugs will work when the inflammatory stakes for the tissue are this high.
I noticed the NHS Lothian pathways also heavily emphasized checking the vaginal pH alongside the culture.
Yes, that's a key step.
Since a healthy vaginal environment is acidic, generally staying under, 4.5, I'm assuming a normal low pH reading helps a doctor confidently rule out things like bacterial vaginosis or trichomoniasis, right? Pointing the diagnostic finger directly back at candida.
That is precisely the logic. Bacterial vaginosis and trichomoniasis typically present with an elevated, more alkaline pH.
Okay, makes sense.
If the pH is low and normal, and the culture is positive for candida, you are closing in on the diagnosis. But there is a massive epidemiological caveat that clinicians must navigate carefully here.
Oh, right, the asymptomatic colonization statistic.
Yeah.
This blew my mind. Up to 20% of women during their reproductive years are colonized with candida species completely asymptomatically.
Yeah.
They have the yeast in their microbiome, but it causes zero inflammation and zero pain. Wait, really?
Right.
1 in 5 women just have this sitting there harmlessly?
It's true.
Doesn't that make the diagnostic process a complete minefield for a physician?
It absolutely complicates things. Just
Yeah.
seeing candida on a lab result doesn't automatically mean it's the culprit for a patient's burning pain.
Right, it could just be hanging out.
Exactly. It could be innocent bystander yeast in a patient who actually has a primary, unrelated nerve pain condition. This is why treating a positive lab result without correlating it to a rigorous physical exam is so dangerous.
So how do they confirm it?
To confirm the physical nerve pain clinically known as vulvar vestibulitis, doctors rely on a targeted, 3-part physical test called Friedrich's triad.
Okay, let's break down Friedrich's triad. The first part is the patient reporting severe pain on vestibular touch or attempted entry, which establishes the baseline hyperalgesia we talked about.
Correct.
The second part is where the doctor actively maps the allodynia using Q-tip palpation, and they specifically target the 5 o'clock and 7 o'clock positions of the vaginal opening, visualizing it like a clock face. Since we know the nerve proliferation is localized, I assume those posterior regions are where the minor vestibular glands and therefore these hyperactive mast cells are most heavily concentrated.
Your anatomical deduction is spot on. The posterior vestibule is where the minor vestibular glands cluster, and it is precisely where we see the highest density of this abnormal nerve proliferation and mast cell infiltration.
Wow, okay.
It is highly specific and highly localized. And the visible evidence of this neurogenic inflammation, the erythema, or redness caused by the expanded blood vessels we discussed, is the third and final diagnostic requirement of the triad.
So what does this all mean for the diagnostic process as a whole? I mean, if a clinician takes a swab, sees candida, and just hands over a fluconazole pill without ever doing the Q-tip mapping to check the 5 and 7 o'clock glands.
Or without checking the pH.
Right. They are working with half a puzzle. They might be treating harmless, asymptomatic yeast while completely ignoring profound nerve damage. The guidelines make it explicitly clear. You have to actively evaluate both the infectious trigger and the resulting neuroinflammatory alarm system.
You cannot successfully treat the infection without addressing the neuropathic landscape it created, which transitions us seamlessly to the actual treatment protocols outlined in the BIH guidelines.
Okay, let's get into the treatments.
Once the stringent diagnostic criteria are met, meaning the clinician has confirmed through culture and Friedrich's triad that an active cyclical infection is actively inducing this temporary hyperalgesia we have to break the cycle.
And it takes a lot to break it.
It does. The standard of care requires a very aggressive 2-phase pharmacological strategy. Induction followed by maintenance.
Right, so the induction phase is all about clearing the active fungal burden immediately. The guidelines recommend oral fluconazole, taking a 150 milligram dose every 72 hours for 3 total doses. So days 1, 4, and 7. Since fluconazole has a notably long half-life in vaginal secretions, this specific spacing must be designed to maintain a sustained, lethal concentration of the drug in the tissue, ensuring every trace of the multiplying fungus is eradicated.
That sustained concentration is absolutely vital for induction. You cannot leave any residual fungal burden that might continue to provoke the mast cells.
Got it.
Once the 3-dose induction clears the active infection, the patient immediately rolls into the maintenance phase. This involves taking a 150 milligram oral fluconazole tablet once a week for a full 6 months.
6 months of systemic oral antifungals. I think a lot of people listening might immediately wonder about the toll that takes on the body. Do the guidelines address the safety of suppressing the system for half a year? Like, are we looking at severe liver toxicity or systemic side effects?
It is a highly valid concern, and clinicians will monitor for hepatic issues and drug interactions, though, honestly, low-dose weekly fluconazole is generally well tolerated by most patients.
Okay, that's good to know.
But the 6-month suppression is considered absolutely essential to halt the pathology. By pharmacologically preventing the yeast from cycling back and blooming every month, you prevent the mast cells from undergoing those repeated inflammatory cascades.
So you're giving the nerves a break.
Exactly. You are essentially buying the peripheral nervous system the prolonged time it needs to calm down, halt the production of nerve growth factor, and allow those superficial hyperactive nerve fibers to gradually retreat.
Now, we established earlier that the culture is mandatory. And one of the main reasons is that Candida albicans isn't the only strain out there.
Right.
If a culture comes back as a non-albican strain, like Candida glabrata,
Hmm.
the playbook changes, right? Because glabrata is notorious for being highly resistant to standardizole drugs like fluconazole.
Yes, if the culture reveals glabrata, or if the patient is pregnant and systemic oral antifungals are contraindicated, the protocol shifts heavily.
What did they do instead?
The guidelines advocate for localized, topical treatments, but deployed very aggressively. We're looking at a high-dose 500 milligram topical clotrimazole pessary, or utilizing nystatin or boric acid suppositories.
And because they're resistant strains, I imagine it takes longer.
Much longer.
Yeah.
Because of the innate resistance of these non-albican strains, patients might have to use these intravaginal treatments for 14 to 21 consecutive days out of every single month, spanning that same rigorous 6-month maintenance window.
Wow. It's exactly like weeding a garden versus repairing the soil.
Ooh, I like that.
Yeah, the induction phase, those first 3 aggressive doses, pulls the weeds. It removes the active fungus that is constantly aggravating the nerves. Then the 6-month maintenance phase is about keeping the soil entirely barren of new weeds.
Right.
It guarantees no new fungal blooms pop up, ensuring those overwired, hypersensitive nerve fibers finally get the extended, uninterrupted peace they desperately need to reverse the structural damage.
That analogy captures the clinical intent perfectly. You have to remove the immunological stimulus long enough for the structural damage to reverse itself.
This has been just a profound look into the medical literature. For you listening, the overarching takeaway is that this kind of chronic burning pain isn't just a stubborn infection, and it certainly isn't in your head.
Definitely not.
It is a fundamental physical alteration of your peripheral nerve wiring, driven by your own mast cells reacting to recurrent inflammation. Accurate diagnosis requires dual confirmation, cultures to identify the specific yeast strain and its sensitivities, paired with rigorous physical exams like Friedrich's triad to map the extent of the nerve pain. You simply cannot successfully treat the infection without understanding the resulting neuropathic landscape.
And if we connect this to the bigger picture, it fundamentally challenges how we might approach these specific pathologies in the coming decades.
What do you mean?
Well, if we know with absolute certainty that it is our own immune mast cells producing the nerve growth factor that causes this excruciating hyperalgesia, could the future of treatment bypass antifungals entirely?
Wait, bypass them completely?
Imagine a world where, instead of engaging in a 6-month systemic war of attrition to suppress the yeast, we deploy a localized therapeutic that simply switches off the mast cell's ability to synthesize nerve growth factor.
Oh, wow.
We could theoretically intercept the pathological signal at the very first sign of an infection, halting structural nerve damage and stopping chronic pain before the first extra nerve fiber is ever grown.
Now that is a thought to leave you with. A future where the body's internal pain alarm gets disconnected before it ever gets the chance to fuse itself stuck. Thank you for joining us on this deep dive into the sources today. Remember, when it comes to navigating your own health, never settle for surface-level answers. Always keep questioning the why behind the symptoms. Until next time.